Warmest greetings to everyone. My name is Kiat, and it is my honor to be speaking at the International Orthodontic Conference 2020. The topic I'll be presenting today, Surgery First, Orthodontic Management. We no doubt regard Edward Engel as a father of modern-day orthodontics. In his teachings, he always believed that the dentition was key in solving many of the problems related to malocclusions, even skeletal discrepancies, and health. He believed that once the teeth are aligned, the face and jaw would be in harmony with the aligned teeth. As orthodontists have been practicing for the past 50 years, we have realized that orthodontics alone wasn't enough to solve many of the problems that can be presented by the patients these days. There was a need to emphasize the face to ensure overall harmony of the facial complex. Treatment of malocclusions with overriding skeletal discrepancies now required not just orthodontics, but orthodontic surgery. Some of the orthodontic surgeries that are commonly used by us orthodontists would include the LaForce, the bilateral sagittal split osteotomies, and of course the genioplasty. Having said that, with now aesthetic techniques, some of these can also be augmented by soft tissues like fillers and even Botox. When we talk more about surgery first, we need to realize that surgery first is actually not really a magic bullet in any way. There are still some limits and boundaries that we need to understand. For instance, the envelope of discrepancy as shown here, whatever we do in surgery first would still need to follow this envelope of discrepancy. And whatever tooth movements is possible in other treatment modalities would also apply to surgery first. Like I said, it's not a magic bullet and it doesn't bind us or unbind us from these boundaries. So what is surgery first actually? Is it a new technique? Actually, surgery first probably was performed many years ago, probably in the 1960s, by a surgeon who performed probably the first orthodontic surgery in the world. At that time, he did not get an oral surgeon, he did not get an orthodontist to manage the case prior to doing surgery, but performed the surgery anyway. It was a BSSO for a class 3 case. And after that case, many other surgeries were also performed for the purpose of correcting skeletal discrepancies. I think as the years go by, the surgeons realized that it was quite difficult at times to solve many of the skeletal discrepancies if the teeth were not at least managed properly. And that's where the orthodontists came in the mid-1980s or so. Over the years, the relationship between the orthodontists and oral surgeons have been very good and established a certain conventional way of doing orthodontics and orthodontic management. By right, orthodontics will be done first, followed by orthodontic surgery, and finally, another round of orthodontics to finish off the case. With surgery first, we are now promoting that the orthodontic part will take second place after surgery is done. And I'll explain to you the reasons why this is so, and why it may be beneficial for the patient's long run. So basically, it may not be a new technique, but an old technique that has been revisited and better established. So the concept of surgery first was introduced by Nagasaka in 2009. Well, in a sense, I would credit him to be the first because he was the one that put on record the first case of surgery first. It was a class 3 skeletal deformity. He did a mandibular setback, and with the aid of temporary anchorage devices, he was able to manage the case successfully and resulted in a reduction in treatment time. There are, of course, concerns for surgery first, but let us look at the dogma for conventional surgery first, or rather for conventional orthodontic surgery. In conventional orthodontic surgery, decompensation is carried out so that after orthodontic surgery, a solid class 1 occlusion can be achieved. There is the stable interdigitation of the upper and lower dentition, which believe or presumably will result in skeletal stability. I say presumably because I strongly believe that skeletal stability is rather achieved, not through the dentition per se, but it's through the plating that the surgeons will actually do during the surgery. So for surgery first, the main concern is because there is no established occlusion, the occlusion is going to be unstable, and that might result in some instability in the skeletal. And as I mentioned earlier, this should not be the case if the plating had been done correctly and properly by the surgeons. Another belief was that there will be occlusal interference that prevents settling of the occlusion post-surgery. Well, again, this can be circumvented quite easily with proper planning. And of course, they believe that the final position of the maxillomandibular complex is based on the predicted final occlusion. So if there is no final occlusion, or rather there is no decompensation done at that time, many fear that because of the instability, it might result in further relapse or future relapse after the case has been completed. What do we know about surgery first now? Well, we do know that there is a huge reduction in treatment time. And the reduction in treatment time, of course, comes from the orthodontic treatment period. For conventional orthodontic surgery management, the orthodontic treatment time ranges from 15 months to 22 months. For surgery first, studies have shown that this range now becomes from as low as 10 months to about 19 months. Of course, we do realize that once the surgery first has been done and the orthodontic phase treatment goes, the orthodontic phase treatment would be based on the severity of the malocclusion that finally has been established after the surgery is done. So it does show that it is still dependent on how bad the malocclusion, how severe the malocclusion is from the beginning. What makes the treatment time shorter in majority of the cases for surgery first? Well, because orthodontics is done post-surgery, there is this RAP effect, or the regional accelerated phenomenon, where there's actually increased osteoclastic and metabolic bone activity in the area of the surgery. So restoring the proper maxillomandibular relationship also allows the soft tissue, the tongue, the lips, and cheek to exert a positive force on the compensated dentition. I'd like to show, or rather share, surgery first approaches, or the surgery first approach that I usually employ when I manage such patients. Usually when a patient comes in, of course, after taking the records, doing the consults and the usual steps that we have to take, I will do a full bond-up for the patient. After the full bond-up is done, I do not place any arch wires, and I will take the records that's necessary for the surgery. Usually for the wire placement at this time, the wires are only placed either immediately before surgery or a couple of weeks post-surgery. At this time now, we also will indicate for any extractions that needs to be done, and the extractions can actually be done on a surgical table or prior to surgery. After all this has been done in terms of putting on the braces and for the patient and taking up the surgical records, we go to the next step to do the model surgery. And in the model surgery, we of course try to establish proper molar relationships and of course proper overbites and overjet relationships. After the surgery is done, the patient will then come back to us for further orthodontics, and this is the phase where most of the orthodontics is taken place. I usually don't recommend any IMF for the patients or even the splints to be kept in the mouth of the patient after surgery. Let me give an example of a walkthrough with this patient, Connor. So Connor comes to us saying that he would like to have his jaws treated because he finds that his jaws is sticking out a little bit too much. One problem that Connor had was that he was going to be conscripted, or rather he needs to go for national service. So he had barely 8 to 9 months to get everything completed, as he does not want to have to go through surgery while he's in the army. As you can see, his malocclusion isn't too bad, but his jaw prominence, especially on the mandible, it's quite obvious. And this possibly would be quite challenging to solve just by orthodontics alone. So as mentioned, we bonded up the case. And if you notice there, those are not arch wires, but just ligature wires to hold the teeth in place. This was all done together with the surgical records, and we sent Connor for surgery. This is some of the things that we do before surgery, taking a face bowl records. And of course, the tracings that we do to plan for the surgery. Of course, in this day and age, there are more advanced methods of doing model surgeries and paper surgeries, but it's always good to know the old and tested ways of doing things, and it gives a better feel and understanding of how these jaw surgeries would need to be performed later on. So we do the mount up, and we get the model surgeries done as well. The splints are produced, and the splints will be integral or very important for the surgeons to establish the transitional occlusion that we as an orthodontist would like to have achieved. This is post-op. As you can see, the wires have been already in the mouth. And this is important to make sure that the wrap effect is fully utilized at this point. 2 weeks post-op. The beauty of youth is people recover very quickly, and you can see that he doesn't really show too much swelling anymore, even after 2 weeks. And his prognathic mandible has been corrected quite nicely. Treatment was about 7 months, and the transitional time showed that he actually had to go in the army before we can complete his treatment. But the good news was the surgery was done prior to him being in the army, so he was quite happy with that. So using the wrap effect, we managed to solve his occlusion quite nicely and get the surgery done altogether in a short space of 7 months. I believe that in this case, if we want to get stability in the skeletal structure, the plating is very, very important. And this is something that the surgeons are very well aware of. You can see that his profile has changed quite nicely to a position that we feel is actually beneficial to the patient. So we talked about paper surgery earlier. What else can we do in regards to just paper surgery? Of course, we have all our computers and planning software right now, from a 3D MD facial scanner to the intraoral scanners, and of course the cone beam CT that would be able for us to be able to study the skeletal structures. All these will help in the planning, but of course the planning is not so easy, because besides all these tools that we have, we actually need an engineer to help to do the planning and integrate all these devices in for the proper planning. So when we talk about surgery first, there's always this question: we have not decompensated or compensated the case in any way. Is that an issue? Well, I've always believed that even with conventional surgery, there is always a risk that we can over decompensate. And when we do that, we also will result in a very non-accurate way of doing surgery first. And we may result in either planning for too much movement in one jaw or the other jaw. And this is, of course, not good for us. It's always a challenge for orthodontists and oral surgeons to determine how much jaw movement there is. And I think as we get better in doing our surgeries and understanding the anatomy better, we need to look at more stable points on the skeletal structure to determine such movements and not rely on dental points for skeletal movements. So setting up the transitional occlusion is actually key in surgery first. In this case, think about it. When we do surgery first and we are setting up the transitional occlusion, what we really want to achieve is for the patient to have a semblance of a class 1 malocclusion at the end of surgery. So in the traditional orthodontic surgery approach, pre-surgical orthodontic treatment is performed such that the skeletal, or rather the dental component, is decompensated to reveal the true skeletal discrepancy. In surgery first, teeth are malpositioned and lack proper occlusal antagonists. The transitional occlusion to be set up post-surgically should be resembling as close as possible to a class 1 malocclusion. So we are now setting up most of these things in 3D. And this helps because there's no more sawing, pouring of models, and it makes it a lot easier for us to plan for surgeries. Again, another orthodontic treatment protocol to surgery first, or rather the same one, but nicely done in a table form. So what are the indications for surgery first approach? Well, in most cases, to start with, I always believe that cases should not need too much pre-surgical orthodontic alignment and decompensation. It should be well aligned to mildly crowded anterior teeth, flat to mild curve of speed, and incisor inclination not overly proclined or retroclined. But of course, we've experienced more complex cases with greater degree of malocclusions and compensations can be attempted. Clinical experience of the orthodontist is critical and crucial to determine model surgery setup and establishing this transitional occlusion, i.e. setting up to a class 1 malocclusion. And of course, a good and experienced surgeon is a must, and a surgeon that you are able to communicate and talk to properly. So overall, surgery first is a one patient, two problems concept. A one patient, two problem concept is wherein a skeletal and dental are two separate problems which need to be addressed in one patient. Hence, in surgery first, the skeletal complexities are corrected by performing surgery, and a transitional occlusion is set up, i.e. class 1 malocclusion, such that the second problem, which is the dental problem, is taken care of, and the reduction and treatment time is there because we utilize RAP when we are performing the orthodontic treatment management part of things. So just talking a little bit about the RAP effect. This was actually first introduced by Frost in 1983, and it's regional, meaning to say that it occurs close to the surgical site of the cut sites. It's accelerated because it does allow for things to heal better, move faster, and in this case, the teeth. And it is a local response to actually noxious stimulus, in this case, the surgery, which describes a process by which tissue forms faster than normal regional regeneration processes. There is, of course, increase of bone resorption activity after bone trauma, osteotomy, flap surgery. And this RAP effect usually lasts for about 120 days. So this is the part where if the orthodontics can be carried out during this period of time, we would significantly reduce the treatment time overall. And of course, this results in enhanced rate of orthodontic tooth movement. We go to another case report to talk about surgery first. Again, this case comes in requesting that he doesn't like a lower jaw sticking out. She feels she looks a little bit fierce and she wants to get it corrected. So we said, okay, I think it will be a good time to do surgery first for her as well. And as usual, we found out a case, took the records for the patient, and sent her for the planning. We did a setback for her and a LaFour-1 advancement with a differential impaction. And as you can see, again, the bonding is done, but there are no arch wires for the patient. What you see in the pictures there is actually ligature wires holding in place. And settling elastics were instituted immediately post-surgery. And if you can look at her, there is no IMF or splints in the mouth to so-called stabilize the occlusion. Instead, the stability of the occlusion is not at this point important. The stability of the skeletal structure is maintained by the plates that's already been placed by the oral surgeons. So settling is started almost immediately. And the settling took probably maybe about 2 months or so. And we got a pretty nice result in terms of the settling of teeth. And from there, we started putting arch wires in. And as you can see, the occlusion is settling in quite nicely. And this was about 7 months later, post surgery. And this was her after completion of surgery. The occlusions has settled in quite nicely. And overall, for a case like this, where the malocclusion was moderately severe, we took about 11 months for completion. Again, occlusal stability only is established after surgery and orthodontic treatment is done. Skeletal stability is actually maintained by the plating that's done by the surgeons. While there could be some links between the occlusal stability and skeletal stability, majority of the skeletal stability would still be determined by the bone plates and screws that's placed in. One other factor that will actually determine skeletal stability is the planning process. Of course, if you plan for movements that is too severe or too dramatic, you compromise overall stability of the structure. If you'd like to read more about some of these cases that I performed, there are quite a few articles out there you can refer to, and this is just one of them. So in conclusion, the key to surgery first is actually profound understanding of orthodontic principles and surgical principles. There is a need to respect orthodontic and surgical boundaries. In the case of surgery first, one of the key things right now would be that the orthodontists have to be more involved in the surgical planning than ever before. So as you can see from my slides earlier, we take responsibility for a lot of the planning and the model surgeries and even the final transitional occlusion, because this is important as you as an orthodontist would be managing a case after the surgery. So you must be able to say that the transitional occlusion that has been established by the oral surgeon is something that you can resolve and complete the case with. So at the end of the day, what it also means is that the working relationship between yourself and the oral surgeon has to be very close. Therefore, you must like your oral surgeon. And with that, I thank you. And once again, keep well and safe. See you guys.